first presenter, who is Dr. Ramakrishnan, Meenakshi Mission Hospital and Research Center. Over to you, Dr. Ramakrishnan.
Good evening, all. My case for today is next slide, please. Is a 64-year male, CA lung, stage 4 disease. The patient was initially diagnosed with a metastatic CA lung in 2023, July 2023. Next slide, please. The patient we did an NGS panel which showed a EGFR Exon 19 deletion, and the patient was started on afatinib. The patient was on afatinib from 2023 to 2025. The patient had partial response. Now, in July month, when we did the PET scan, it showed a progressive disease. Later, we did a liquid biopsy, which showed resistance pattern EGFR for T790M mutation plus TP53 mutations. Next slide. We did a liquid biopsy in October month, which showed EGFR T790M mutation and TP53 mutations. Now the patient was started on Pemetrexed and carboplatin along with Osimertinib. The question for today is the significance of TP53 mutation along with EGFR T790M mutations. The combination of both will Osimertinib work in TP53 mutation compared to TP53 wild type. The next plan, now we have started the patient on Pemetrexed plus carboplatin along with Osimertinib. Go to panel members. The next.
Can you go to the NGS report?
And NGS, this is the previous report in 2023 report. Previous slide. Yeah. This is the recent one. A recent one which showed liquid biopsy showed Exon 19 and T790M mutation and TP53 mutation was detected. Previous slide. Previous slide, please. Previous NGS report which showed EGFR Exon 19 deletion.
Okay. Both are hotspot mutation, what you have sent, right?
Yes, sir. Yeah.
Okay. Thanks, Ramakrishnan. I think we'll get the molecular expert's opinion.
Okay.
Who would like to start?
Yeah. So can you go back to the VAF percentage of these mutations, basically?
Sir?
VAF
next slide.
I think next slide. Yes.
Not
this one.
This is the recent one.
This is the recent one, but the VAF percentage will be mentioned in the next page.
Next page. Sir. Yes.
Next page. Yeah. Hold on this one. So if you carefully looked into this VAF percentage of all the mutation, still the EGFR Exon 19 deletion seems to be the dominant clone, which is 27.6%. Followed by the treatment with afatinib, given the resistance mechanism in the form of T790M, that's why you are seeing a different clone of 12.9% as a resistance mechanism to the afatinib. Having said that, there are other two mutations which are present in the very, very mild level, 0.12 and 0.25. So it's an excellent decision. Already T790M mutation is present. You went for FLORA 2 trial data, which is chemotherapy along with Osimertinib, basically. Now the major question is whether the implication of T53, what will be the implications basically, and what to go forward for the next one. Am I right to say?
Yes, sir. Yeah, that's the exact question.
So what I would suggest here,
EGFR 20 also is there, right? That also significant buff. What is the third mutation that we are seeing? Is it EGFR Exon 20? It is.
Yeah, sir. EGFR 20, sir.
Exon 20, which is the resistance mechanism for the afatinib, which is the T790M mutation.
Yes, VAV is the second prominent clone. You can see almost 13%.
Almost 13%.
It's like a dominant clone.
Yeah, that is because of the afatinib, sir. Definitely that will respond to the Osimertinib treatment when we are giving, along with the chemotherapy, that will be taken care already. So the Exon 19 clone, which is the second variant, and the EGFR Exon 20 variant, both of them will be taken care by the FLORA 2 current treatment currently. The other two mutation, which is T53 and EGFR, especially these R175, there is a one paper publication is there, but not very much. Just for the academic purpose, it will be helpful. whenever they R175 is mutated in the T53, basically, they may not respond beautifully to immunotherapy. There will be immunotherapy small negligence to the immunotherapy response. R175. That is the paper publication suggested. I will share the same evidence to the team member over here while during the discussion, and then later, if you want, you can take it up. But it is only one paper publication. It is only for academic discussion. There is no solid evidences is available. On other hand side, if you look at the clonal variant, it's only 0.2%, and another one is 0.25%. This kind of small variant easily will go away whenever you are combining with chemotherapy. So after the osimertinib and chemotherapy combination, if still this dominant clone is getting into the higher side, if the dominant clone is going into the higher side of 1%, 2%, 3%, then you can think about twice that the patients may or may not respond to the immunotherapy in the next line, because once the patient is progressed from osimertinib, the options are very limited. So you need to go back to your keynote trial data, which is EGFR progressed patient, or IM power 150, which is also patient progressed from EGFR data for the immunotherapy usage. So currently, osimertinib is good choice, but follow up this T53 as well as the EGFR clonal population, whether it is coming up or coming down. So if it is coming up, then we can see that there is going to be a response. It will be very hard to think. And other than that, T53 175 is aggressive in nature. The tumor will behave aggressive in nature. These are the two information you can get out of it, basically.
Okay, sir. Thank you, sir.
Thank you.
For 18 mutation, it was there initially also. Can you go to the first mutation, first report?
First, previous slide.
No, sir, it wasn't there. Previously, it showed only the Exon 19.
Only Exon 19 deletion.
No, in below the table, something they have mentioned, suboptimal QC. Can you go back to
previous slide, sir?
Yeah, that is a 598 position.
No, before. No.
Previous slide. First. And this one.
Okay, that's a different one.
Okay.
So below the table, some mutation I mentioned. Here. Yeah. So that's a different mutation.
Okay.
So that means we can assume that earlier the T790M mutation is not there. So currently T790M mutation is present. So that means most likely it is afatinib resistance mechanism is developed through T90M, which is very common. More than 30% of them, when afatinib is exposed, this T790M mutation will come. And already the doctors have taken the excellent decision of going for the FLORA 2 trials, so which will taken care of EGFR Exon 19 as well as T90M. So only concern here for the panel is what will happen to the T53 R175 as well as the other mutation which is present, which is very small level, that should go away with the chemotherapy already you have combined. If it is not going away, the tumor will begin aggressively. Already I have shared the evidence also in the chat box. So people want to refer, they can refer it.
Thanks, Dr. Silamarasan. Ramakrishnan, my thoughts for this case is your plan of starting PEM carbo along with osimertinib. Yes, I think most of us will do that. But P53 mutation is there. It's a resistant mechanism. We know that this patient is going to progress in near future. The typical osimertinib response we are not going to give, because osimertinib we are giving in the second line, and there is a resistant mechanism. Patient is going to progress, but next time when the patient progresses, I will always think of going for a broader panel rather than the hotspot patient. So I will think of, I will discuss with the patient now only that next time probably a broader panel, comprehensive genomic panel will be better rather than the hotspot. This is what is coming to my mind. Others can share your thoughts. Anybody else want to?
Kripa here, sir.
Yes, Kripa.
Hi, Ramakrishnan. So, as far as is concerned, see, this is one of those patients, the classical EGFR exon 19 deletion, and is gone on to develop on-target resistance mechanism, which is one of the most commonest mechanism to first and second generation EGFR TKs, the T790M mutation. What's so interesting is he's also developed a co-mutation, the P53 loss of function mutation, and we know that's a poor prognostic indicator. Meaning patients with a co-mutation don't respond as well to just a single agent TKI alone, or even if it's a third generation TKI. So the only question here is, should you combine it with chemo, or is there data to do it with VEGF inhibitors, like either ramucirumab or, with the data for ramucirumab plus erlotinib, Relay data, where they've done a subgroup analysis looking at patients with P53 mutation alone, and the magnitude of benefit was still preserved in those subset of patients. But again, all the data that we are discussing right now is all based on extrapolation from the first line. Whereas you are talking about somebody who's progressed on even the FLORA 2 data or everything is based on first line. Whereas what you're talking about here is second line. Second line, the data that we have actually is only for OSI. But nevertheless, because of the co-mutation, you justified in actually adding chemotherapy. So I agree with your plan. But the other thing is, you contemplate, the other thing that can be contemplated is also VEGF inhibition. Again, because you have P53 loss of function or co-mutation and the data with ramucirumab plus erlotinib. And interestingly, OSIRAM and RAMOS, 2 studies looking at osimertinib plus ramucirumab as well. But unfortunately, one was phase 2 trial, the other was a phase 3. One was a positive trial, OSIRAM was a positive trial, but the other one wasn't. So giving ramucirumab probably once in 3 weeks didn't work out, but they would try giving it 2 weekly. That was one of the major differences between both the trials. But having said that, I think, as far as the treatment strategy is concerned, we know this is a poor prognostic indicator. Patients may not respond as well, because of mutation. So you're justified in adding chemotherapy. I agree with your plan of osimertinib plus chemotherapy. And like Dr. Arun suggested, probably look at getting a broad-based NGS done at progression, at least then.
Okay.
Rather significant mutations.
Thank you, Dr. Kripa. I
Thank
think we'll, Dr. Kiran, Dr.
Sir,
Vijay.
one doubt, Dr. Vijay here.
Yes, Vijay.
Sir, Kripa sir also. In second line, whenever we are talking in lung, we add ramucirumab with docetaxel, ramucirumab with erlotinib, and that time we don't think about squamous or adeno. Is there any logic to it?
Yeah, Vijay. So I think, see, this is the data that you're quoting is based on the REVEL study, which is for ramucirumab plus docetaxel. They included around 25% with squamous histology. And that's why we say, okay, fine, you could use it in both the histology. But historically, if you look at it, bevacizumab, there is always a risk of increased bleeding within squamous histology, which is why people have refrained from moving away towards bevacizumab. But again, another point to highlight is bevacizumab and ramucirumab are not the same drugs. There is a difference in the mechanism of action. Bevacizumab acts on the ligand, the VEGF-A ligand, whereas ramucirumab acts at the receptor, the VEGFR-2 receptor. So, which is the reason and the rationale as to why ramucirumab is considered to be safer, especially in the second line, and can be used in the squamous histology as well.
So we need not equate ramucirumab bevacizumab. That is the take.
That's right. Absolutely. The key take home should be that do not use it interchangeably because they're not one and the same drug. And there's a definite difference in the mechanism of action, Vijay.
Okay.
Thanks, Dr. Vijay. Dr. Kiran, any thoughts from your side or any suggestions?
No, sir. Completely agree with, I think all the points have been discussed.
Thanks, Dr. Kiran. Narendran, can you make the consensus?
This 64-year male, a case of carcinoma, metastatic carcinoma lung, upfront classical EGFR exon 19 deletion, progressed after 2 years of now with the targeted NGS panel, liquid NGS suggestive of T790 mutation, along with a point mutation in the exon 18 and a co-mutation TP53. The final consensus is to go ahead with osimertinib and chemotherapy. On future progression, to consider for a broader NGS and decide.
Thanks, Dr. Narendran. We'll go to the next case, case 2. The presenter is Dr. Lakshmi Tilak from Madurai Meenakshi Mission Hospital. Over to you, Dr. Lakshmi Tilak.
Yeah, sir. Thank you, sir. Good evening, all. Today I am presenting a case of a 62-year-old female. She is a case of carcinoma right breast triple negative breast cancer, stage 2 at diagnosis, and she was diagnosed in January 24 with an ECOG performance status of 1 with comorbidities of diabetic and hypertension. She had a family history of carcinoma endometrium in her elder sister. Next page. She underwent wide local excision of the right breast mass, followed by chemo, neoadjuvant chemo, that is pembrolizumab with with carbo, then modified it to pacli carbo alone due to toxicity. Then she underwent right MRM in May 2025, which was a pathologically complete response. She received post-op RT, then followed by 1 year of maintenance capecitabine. She took till August 2025. According to last imaging, she had complete response, and we done hereditary cancer gene panel for her. Next page. Next page. Which shows the mutation in APC gene, that is BRCA, BRCA1 and 2 is negative, but incidentally we have an APC gene mutations, which is considered as pathogenic, autosomal dominant. So based on this report, any relevance for APC gene mutation in triple negative breast cancer in the further management and surveillance of this patient?
Thanks, Dr. Lakshmi Tilak.
Thank you.
Brinda is there, genetic counselor, Dr. Brinda?
Yes, doctor.
Yes. Brinda, your thoughts on this? Then
from the germline aspect, it's a little very rare to see APC for breast cancer. But this definitely correlates with the endometrial history, cancer history in the surviving sibling. So from that perspective, I would like to cross-check if she also has the same variant. But in terms of guidelines on management, I would ask the other experts to please pitch in. But from the familial angle, we need to cross-check if the sister also has the same variant, so that counseling rest of the family members becomes very crucial.
Okay.
What about the screening for this patient, Brinda? That is also another important, right? The APC. Although the relationship between breast and APC is not defined, still,
yes, doctor.
So we need to screen them early, and we should start like a FAP protocol we should follow, and early colon cancer screening we should start for this patient, right? That discussion.
One cross check would be to get a deletion duplication analysis, because I see only NGS done here. I think it's not a comprehensive gene panel, it's the SNV panel. So a digital MLPA just to rule out other BRCA variations, if at all it is there. So that would be one part, and there's definitely the surveillance protocol as per the APC gene. Yes.
Okay, thank you, Brinda. Others, other specialists? Yes.
Dr. Pushpa here, sir.
Yes, ma'am.
So here, if you see APC gene, as ma'am asked, being germline, sister being endometrial, suspicion of endometrial cancer, the chances of again Lynch may be there here, and or FAP you can say, because APC gene is very common in FAP here. And other thing is, as far as management is concerned, APC gene does not have any therapeutical implications in terms of the cancer what right now TNBC is here. And one more thing is, APC gene has a resistance or a less sensitivity towards the immunotherapy, basically. So immunotherapy is, if considered here, then this APC gene has a tendency to reduce the T cell infiltration, as well as to reduce the immunotherapy reaction. Hence, in terms of therapy management, APC gene may cause some hindrance to the immunotherapy. That way you can consider here. But as far as just like BRCA1 and BRCA2, how they have implications to PARP, we cannot consider APC gene here in terms of management. And germline, since this one is there, I agree with Brinda that we have to again further screen maybe if any other mutations we can get in the family, so that other things can be ruled out before going for a regular checkup of colonoscopy or something.
Okay, thanks. Any new thoughts other than what has been shared by Pushpa Singh and Dr. Pushpa Singh and
Few
Brinda?
doubts. I think this is a germline mutation, if I'm right. What has been done? It is picked up. So
Exactly.
this is like we call it as an incidental and has no relevance to the current management of the cancer.
Breast cancer, yes, sir.
So basically we did and then we picked up.
Yes, sir.
Yeah.
So just like that we picked up, and now can we call this as patient with the possible FAP and so on?
Yeah, so I think what the thing is, we need to, because it's a APC mutation is there, what the patient develop, probably it's a sporadic, it's irrelevant to the germline mutation. Definitely we need to refer to a genetic counselor. This report should be discussed in detail with the patient. And after taking the patient into confidence, then screening protocol for the patient and cascade testing for other family members, definitely we should do. So,
FAP, even FAP screening starts at 10 to 12 years. So probably we should start screening for other cancers
absolutely.
associated APC.
Yes, because germline mutation is there. Others can also share.
Yes.
A difference of opinion, please share.
The presenter as well. I mean, like you said, you stopped immunotherapy because of toxicity, right? What was the toxicity?
Sir, actually, she was treated outside, sir. She just presented 2 months back as a follow-up. After finishing the capecitabine only, she came to us. So we don't know about the toxicity. Sir?
Okay, because you also mentioned that the patient has achieved a path CR, right?
Yes, sir. Yes, sir.
Yeah, the patient has responded well to your neoadjuvant systemic therapy, but I was just wondering why probably the IO was stopped. And as we all know, APC is a very cold tumor microenvironment, so IO doesn't actually work well in people who have an APC mutation, as like Dr. Pushpa Singh also rightly pointed out that. So I was just wondering to correlate the path here with, but probably even the chemotherapy alone would have probably done the trick here.
Yes, sir.
I agree with everyone else as far as screening for colon cancer here is concerned, ruling out FAP, attenuated FAP as well, follow the surveillance guideline for colonoscopic surveillance.
Okay.
Thanks.
Sir, just, sir, one more thought actually, Kripa sir. The patient we have done the testing is the germline testing. Okay, if the APC mutation is present in the patient's somatic tumor testing, then we can say that the patient's tumor microenvironment may be cold and they may not respond to the immunotherapy. But in this case, already the patient have responded beautifully to immunotherapy. Only because of the chemo tolerability, they have changed, reduced the dose. But the latest PET scan after the capecitabine treatment, they have achieved the complete CR. So that means they responded to immunotherapy.
We don't know whether it was to immuno or chemo. No.
No. Yeah, it may converted.
No. From the history, whatever has been pointed out is that they've stopped immunotherapy.
Stopped Pembro alone, sir. She received 1 or 2 cycles of Pembro. Then, due to toxicity, this is what we got from the patient, sir.
So they have stopped and continued only the chemotherapy.
Continue only the chemotherapy. And on top of that also, this is only the germline testing of APC. So first thing, we need to prove that whether this APC mutation is present in the patient's somatic conditions also or not. Then only we can go for the segregation analysis in the family member, especially the endometrial patient who affected the sister also need to be tested for the same mutation. Then only we can go for the non-affected individual family member. So we need to have 2 strong correlation. First testing the breast cancer patient with the same APC mutation, then followed by the same endometrial cancer patient having the sister having APC mutation. Then both of them can undergo for the subjected to the colonoscopy after the proper genetic counseling. If any one of them have identified any polyps in the imaging data, then we can consider the other family member to subjected for colonoscopy on an annual basis or not. So this is only the hereditary gene testing. We cannot immediately jump into the conclusion of screening unless otherwise we establish this APC mutation present in at the tumor causing level, basically.
No,
I'm sorry. Germline and pathogenic as well. I mean, like,
yeah,
you can go ahead, sir.
Sorry, sir. I think we both are alluding to the same point. Please go ahead, Dr. Kripa. Yeah.
So this is a germline and a pathogenic variant as well that's been picked up on germline testing, Salamberson. So why would you think it's not significant?
No, sir. What I'm saying is that what I'm saying is that now it's definitely it is significant, sir. Once it's established as pathogenic, definitely it is going to be significant. What I'm saying is that it need to be tested with a family causing, means other family member who are affected with the cancer also need to be tested before we go into the non-testing phase, non-cancer affected individual. That's what I mean to say.
Yes. You're talking about aggregation analysis and cascade testing, which is fine. But I think, maybe not relevant for the breast cancer per se, but for the colon cancer screening guidelines, yeah, definitely APC is valid.
Thanks, Dr. Silambarasan.
Sir, I have,
Yes.
I just wanted to ask a doubt, sir. Let us say this patient is already 62 years old and has not developed, has not had any GA symptoms. The incidence of the lifetime risk would actually approach 100% by 80 years of age for anybody with a APC gene mutation for colon cancer. Supposedly, let us say if this patient undergoes colonoscopy and not much polyps are there, do we doubt the NGS report, or is there any role to recheck, or can we actually take this NGS report at its face value and say it is actually correct, or at what point do we recheck or do it in a different labs?
Thanks, Dr. Gren. Actually, Dr. Brinda was mentioning she would like to confirm this NGS report with MLPA. Before going for further testing. That's what she said.
So before that MLPA, can we actually tell the patient that we have pathogenic mutations?
Definitely we should disclose. Once the report comes, that's the problem with NGS. Once you send the report, all the pathogenic mutation, whatever the results comes, we need to sit and discuss. Definitely we need to discuss this particular report, and even that end only genetic counselor should be involved. Even before sending for MLPA, genetic counselor should be involved, and then with their concurrence, taking that them into conference, then together probably a shared decision making should be done to for sending to MLPA. Then once that result comes, probably another round of counseling will be required.
But I thought what Dr. Brinda meant was, sir, for about the large genomic rearrangements being missed, and hence an MLPA for BRCA considering the CNVs.
Yes, doctor. That was my primary point, because this had primarily considered only single nucleotide variants.
Perfect.
As far as the APC is concerned, we'll have to follow surveillance protocol.
Correct.
But the breast cancer, in my opinion, could either be sporadic or are we missing something on the deletion duplication? So that was my point.
But Arun Kumar and Brinda, when you get a NGS report, would you like to, like most of the time when I send to a genetic counselor with that report, always a final note will be there, confirm with MLPA will be there.
I think that was
always.
Mostly if it is a negative report, no, sir?
No, even if it's a positive, even the NGS, because it's a sensitivity pattern of the NGS. But I think the present third generation NGS, I think the chance of being false positive is very low. But most of the genetic counseling report, if you see, if there is a mutation picked up in the NGS report, they will always tell you we would like to confirm with MLPR Sanger sequencing before taking it to next.
Depends on the coverage, doctor, because where the probe coverage is high or low, it depends on every panel. So, so that was probably the reason why most reports do recommend an MLPA, wherein you're covering all the exonic regions and along with certain intron-exon boundaries. So, and the type of deletion and or error in the DNA that is being assessed for in NGS is different from that of a MLPA. So the scope of the test is also very important here. So that is the primary reason. Mostly, as you say, current generation NGS do pick out deletions, duplications, but again, it is not foolproof.
Okay. Thanks. Yes.
At 62 years old, still we see a APC. Can it be a contaminated chip here? Is it possible? Because 62 years APC gene.
Very rare, doctor, because this is a germline testing, which means the depth of sequencing is going to be 150x, and you don't generally pick up chips in that low frequency. I don't see the possibility of false positive in a hereditary cancer panel to be significantly high. So I don't see I should, although it's a incidental finding and it doesn't fit with the clinical phenotype of TNBC, I still don't think we need to doubt this particular report, because with confidence I can say it's a hereditary cancer panel in any Indian lab, it's doing very well. So that's my point. And secondly, as already discussed, that element of doubt can be removed if the affected sibling is tested for the particular variant and turns out to be APC positive, because APC can still cause endometrial cancer also. So I think follow up with the APC mutated cancer-based recommendations for screening is definitely recommended. If we are really academically oriented, if any lab allows, or if the patient is interested, you may want to do a genomic profiling in the tumor tissue. It's purely for academic reason, just to see what is a driver in that tumor, apart from APC causing TNBC, or is it really APC, a novel case causing TNBC here, which has not been reported earlier. That would be a academic interest that I might want to look upon. Otherwise, it's a we can trust this APC mutation.
Okay. Thank you, Dr. Arun. Narendra, can you summarize so that we can go to the next case?
This patient, just a doubt. This patient, as panel suggested, should we go for MLPA and then go for a Sanger sequence, just to confirm only for MLPA. So should we go for MLPA after the report comes, then go for Sanger sequencing of family members?
No, you can go for family member first, because already a pathogenic variant has been identified. So it is very prudent to test the other affected sibling first before testing the unaffected family members first degree.
Whether MLPA 2 and then if the BRCA is positive, then you screen both. Sanger sequencing, you see particular mutation for both the mutations, or
no, Sanger cannot pick up what has been picked up in an MLPA, because MLPA picks up large deletions and duplications. So if at all you pick up something in the MLPA, you again have to do only an MLPA. You can't do that in Sanger. But looking at the pathogenicity of this particular variant, it's much easier to do the Sanger first in the other family members, or particularly as I said, the affected family member.
Okay. So the final consensus is to go Sanger sequencing of the family members and to consider MLPA in the patient to look for any BRCA mutation which is missed in the NGS, and also to go for colon cancer screening for this particular patient.
Thank you, Dr. Narendra. We'll go to case 3.
Thank you,
Case
sir.
3 will be by Dr. Mangai Susila. She's from Kaveri Hospital, Trichy. Over to you, Dr. Mangai.
Thank you, sir. Good evening to all. So today I'm presenting a patient who is a 49-year-old female diagnosed as breast cancer. She's presently she has progressive disease, and she has no known comorbidities with a performance status of 1. And family history, there is a doubtful history of malignancy in grandmother. It was not very clear cut from her history. So her case details, she was initially diagnosed with a locally advanced breast cancer. It was T3 and N2, and it was a triple negative subtype. She was treated with neoadjuvant chemotherapy protocol, 4 cycles of AC, adriamycin cyclophosphamide, and 2 cycles of nab-paclitaxel. Subsequently, they have added 2 cycles of nab-paclitaxel carboplatin. But she did not have much clinical response to all these chemotherapy subsequently. So they have done a repeat biopsy also in July, which was also a ductal carcinoma with a triple negative subtype. And after 8 cycles of chemotherapy, a PET scan was repeated. PET scan was done. Previously, there was only a contrast CT chest. Now the PET scan was showing extensive bone and nodal metastasis. So then she came here. Now she is currently on eribulin. Again, a repeat biopsy was done, which was showing an infiltrative ductal carcinoma only. Subsequently, next slide, please. Next slide. Please show the NGS report. So this is her NGS report. She has low TMB, MSI stable, and HRD score was very low, 44, but positive. And she has a TP53 mutation, MCL1 copy number gain, Richter copy number gain, and next slide, please. And TRT copy number gain. So please go back to the questions. So clinically, the patient after 2 cycles of eribulin also, she has not responded. Her lump in the breast and in the axilla, there clinically it is increasing. There is a small nodule also over the tumor. So what I wanted to know, what is the mechanism for this chemorefractiveness? And second question will be, for a triple negative subtype who are present with a locally advanced disease, will upfront NGS be helpful to identify the subset of patients? And for this patient, presently, she is not responding to eribulin also. Immunotherapy also, I don't know how it will be effective with TMB low and MSA stable. So any role for this everolimus and etoposide combination for this patient? Thank you.
So, Silambaran and Arun sir, your thoughts on the NGS
Okay,
report?
I was just trying to digest that. So, so yeah, number one is that this seems to be a tumor driven by TP53, and whatever next we are seeing are all amplifications. There is a Richter amplification, there is a TERT amplification, and there is a MCL1 amplification. Now, MCL1 is what do you call it? It's a gene that is involved in BCL2 based mechanism, and it is associated with chemo resistance. There are multiple cellular studies to show that chemo sensitivity reduces whenever there is a MCL1 being present. So this is that could maybe, and the copy number of the MCL1 is almost double that of Richter and TERT. So this is one thing. Now, Richter and TERT are genes in the same chromosome. If I'm right, both of them are in the fifth chromosome. So what you essentially are seeing is maybe something related to polyploidy, where multiple chromosomes chromosomes are being amplified, or you have chromosomal amplification happening. So that's the reason why you're seeing both Richter one as well as this one TERT being amplified with the same copy number of 8. If you can see in that report, it says that. So whether that is actionable, I'm not sure. Richter is a part of the mTOR pathway. So yes, you may want to add there may be some role of everolimus here. But with just a 8 copy number and a Richter amplification, I don't have clinical evidence to show that, but biologically or mechanistically, yes, everolimus does have a role because it targets the same pathway.
Dr. Arun, if I'm not wrong, if you see the report, it's only copy number is 5, not even 6. The cutoff is 6 actually, right?
Just go to the.
No, it's 8 and 16 is given. 8 and 16.
8 and 16, huh?
Richter and TERT are 8 and MCL1 is 16. It's below. Can you just come down? In the next page, it's
I'm seeing as 5 only. I'm seeing
here.
Different.
Here, MCL1, Richter and TERT. MCL1 is 16. Richter and TERT are 8 within brackets borderline, respectively.
Oh, yeah. Okay. All of them are in the borderline category, basically. Their cutoff is 8. Okay. Okay, but as you rightly said, I'm seeing all these are copy number of polyploidy kind of copy number. Usually these kind of things may not respond to the treatment of everolimus, basically. And this one interesting thought what I have is, usually this T53 mutation in the TNBC is common. As you mentioned, it could be a possible of driving the cancer. And 1 or 2 anecdotal evidence is available for 2 reasons. One is when T53 mutation is present in the TNBC, that could be TILs or higher side of it, tumor infiltrating lymphocyte. So what the clinician can do is go back to their pathologist and ask them to verify in the tissue block whether any lymphocytes, infiltrating lymphocytes are in the higher side of it or not. So what we know in this NGS report is T53 is already high. So what the anecdotal evidence is suggesting is the T53 mutation patient may have the TILs. So if we can able to verify that TILs are present, then the option of immunotherapy may open up for this patient in the later setting. Immediately they can consider for that. Considering if the PD-L1 testing need to be done, they can go ahead and do the PD-L1 testing with a CPS score more than 10, pembrolizumab will be available. On the other side, the T53 mutation, what it is going to tell us, the patient is poor in the prognostic indicator, which we are currently seeing it. The patient has been exposed to few chemotherapy molecules, but they are not at all responding to the treatment. So that are the two incidents we can take from the T53 mutation. The rest of the amplification, I didn't see have much implication for the patient, basically.
Like HRD
This
positive,
patient,
42.
PD-L1 is 0, sir. IHC PD-L1.
PD-L1 is 0. And how about TILs? TILs they have, can you able to check it out with the pathologist?
I will enter, sir. That I will enter, sir.
Dr. Silva, HRD positive here, it is slightly just
Yeah.
40, slightly
I think
above. So what is the significance? Whether
Dr. Arun, I think this is the second time we are seeing in our tumor board, second or third time, the same HRD score algorithm, which is called here as GAS, genomic aberration score, if I'm right, being there without a root cause being from any of the BRCAs or other HRR gene mutations. And if my memory goes right, the cutoff value for this particular algorithm of GAS in this lab is 40, and this is just borderline positive of 44. So I would take it with a pinch of salt before acting upon the HRD. And the patient has already been exposed to platinum too, right? And how was the response?
Yes, sir. The last 2 cycles, they have added carboplatin also, but she has not responded, sir. Clinically, the lump is still there. It is painful. It is increasing on.
Sorry, sir. This is Vijay here. One doubt. We have a HRD scoring which is based on all those parameters, and that does not have to actually always have a HRR based HRD scoring, right? The TP53 and the TERT might have actually made the HRD score to be high.
TERT, I'm not sure. TP53 very rarely leads to a high HRD. But yes, I agree. You can still have BRCA methylation causing HRD, or you can also have so-called unknown mechanisms causing HRD positivity. I don't discount that at all. But in our experience in this tumor board, I think this is the third time I'm seeing a HRD positive report without a response to platinum. So,
is there any any logic, because so many treatment has been tried, nothing is working in this case. The patient is resistant and HRD is positive. Is there any role of platinum plus PARP inhibitors or only PARP inhibitors? What will be your thoughts on this? Because see, you don't have options now. We know that although HRD is 42, it's not behaving the way DNA repair pathway is defective. The way it behaves, it's not behaving because platinum response is not there. But still, we don't have much options. Patient has been exposed to anthracyclines, taxanes, eribulin, capecitabine, platinum, all has been exposed. So it's a hormone negative cancer. So can we think of adding a PARP inhibitor, seeing whether it works? Is there any role of adding platinum plus PARP inhibitors in this particular case?
Sir, Arun, sir, already the patient is exposed to platinum-based therapy, and it is not responding very well.
PARP inhibitors with platinum.
PARP inhibitor,
both
very less chance, sir. Already Dr. Arun mentioned it, right? PARP inhibitor is not going to respond much because the gas score, whatever we are seeing, the HRD gas score, doesn't have any of the HRR gene. And Dr. Vijay have asked actually, the TERT, what we are seeing here is the copy number variation. So the copy number variation, especially TERT, is not at all going to contribute to for the HRD score system. So from that angle, maybe even if you want to consider PARP inhibitor, my humble suggestion is go for one more lab testing of purely HRD testing instead of gas-based testing, right? So you can go for the one more HRD testing from Strand or whichever the company the patient can afford and comfortable. We can go for the pure HRD testing once again and then consider PARP inhibitor rather than directly going into the PARP inhibitor right now. Basically, that's what my suggestion would be.
So yeah, Kripa here. So Mangai, you said you have repeated a biopsy as well, right? What is the HER2 status on it? Is it like low, ultra low, anything?
Sir, the ERPR HER2 we didn't repeat here. It was repeated twice outside, sir. So I didn't repeat. It is HER2 0, sir. 0.
So I think it would make absolute sense for you to repeat a HER2 status now. See, because if it is low or ultra low, it throws up another option, treatment as far as treatment is concerned. You could contemplate TDXT number 1. And number 2, if your patient can afford it, go for Seshachalam govitecan, which is already approved for TNBC. The other option is Dato-DXT. So all these ADCs are options if your patient has not responded. And again, coming back to the molecular profile here, like Arun sir rightly pointed out, MCL1 amplification is probably involved in anti-apoptosis, which probably could explain the chemo resistance, number 1. And it's also more common, you asked whether you could do it in the adjuvant setting as well, right? See, I mean, like a lot of work has been done on identifying molecular subtypes of triple negative breast cancer. This closely fits into a basal-like 2 or basal-like, which is the most commonest subtype of triple negative breast cancer, molecular subtype, I mean, right? So it's also worthwhile checking for the AR receptor also, androgen receptor.
Okay, sir.
So they're calling it quadruple negative breast cancer now, especially if it's luminal subtype and all basal. Here, even though it's basal, it's worthwhile checking for the AR receptor. And if that's possible, we can look at targeting the AR as well. All right. So those points as well. And again, your point of adding everolimus because the mTOR activation is there and the Richter gain based on the Richter gain, I think that's again off-label anecdotal. So my suggestions would be look at checking on the HER2 receptor status again. If it is low or ultra low, go on to TDXT. If not, go on to Seshachalam govitecan or Datopotamab deruxtecan, Dato-DXT in that order. That would be my order of preference. And
actually is not affordable, sir. This test only I convinced her nothing is working, so we will try. So
okay, but again, I mean, based on the HRD alone, I think this is not a great idea because again, as a tumor agnostic indication, HRD, especially with this cutoff from this particular lab, like has been already been pointed out with no response to platinum as well in the prior. I think already platinum twice and hasn't responded. So I think this would be these are all the options that you're left with. So it would be worthwhile checking on the HER2 status as well again. Slower ultra. And probably you can even try low TDXT if cost is a constraint. See, probably now they have a PAP of 1+1, so you could try just 100 milligrams if they're okay with it. That's
How's
another.
the GC, Mangai?
Sir?
General condition?
She's PS1, sir.
Yeah.
Stuff.
So yeah, I think So see, I think a lot of labs are currently trying to look at doing gene expression profiling as well to identify molecular subtypes of triple negative breast cancer. But even though that may sound far-fetched, could look at at least doing an androgen receptor, AR receptor can be done as well. Apart from this, and check on the HER2 low or ultra low status as well, Mangai.
Yes, sir.
And based on whatever cost they have, you could even try low dose ADCs as well because all the dose finding studies have used even a lower dose of TDC as well.
Yes, sir.
Dr. Mangai, as Dr. Kribashar has suggested, going for AR testing also will be useful. Basically, before going for AR testing, again you can go back to your pathologist to check in the tissue block in the microscopic any apocrine features are there or not. So AR means most likely the patients may have the apocrine feature in the histopathology. So check it out. If apocrine feature is there, definitely there is a chances that it could be TNAC, which is a triple negative with apocrine feature with androgen positivity can be there, androgen receptor positivity. So before androgen receptor testing, that will give you additional confidence or clue to communicate to the patient. The AR testing will be worthwhile for the patient, basically. So apocrine feature testing will be useful.
Yes.
Again,
Dr. Chandramoulishwari madam is there. If she, madam, any suggestions from your side, ma'am? Repeat biopsy, seeing the histopathology again. Anything from your side, ma'am?
Sir, yes, I was listening intently. It was an interesting discussion, I should say. like sir was pointing out, yes, apocrine may be there. As you rightly said, AR positivity, yes, it happens in tumors like triple negative or ERPR positive tumors, but apocrine may be there, and apocrine metaplasia in a breast or even in a salivary gland also will show androgen positivity. But the point I'm trying to make is all androgen receptor positive tumors need not show apocrine metaplasia. Apocrine metaplasia, if it is there, most of the tumors will show AR positivity. That is all is my understanding. And tumor infiltrating lymphocytes, sir, it will definitely be present is what I would like to say, sir. Tumor infiltrating lymphocytes will be there. But there is a scoring methodology, isn't it, for tumor infiltrating lymphocytes? There is an AI algorithm also, and there is a manual scoring methodology also, which is in vogue, which is in practice. But not many centers, I'm not aware that if many centers are getting into the practice of calculating the tumor infiltrating lymphocytes. But if you do it, I think it will be valuable. And just looking under the microscope for the presence or absence of tumor infiltrating lymphocytes may not be of help, is what I would suggest. And even if it is a tumor infiltrating lymphocytes, immunohistochemistry is also used for us to find out if it is a helper or a suppressor T cell, meaning CD3 along with CD4 and CD8. And a calculation based on these three markers is what should ideally be done if we really want to comment about the tumor infiltrating lymphocytes, is my understanding, sir. Thank you.
Thank you, Dr. Chandramouli ma'am. Thank you very much for the input.
So just to add what Madam has said, sir, I think, that's a very valid point. Not all AR positivity needs to be apocrine, number one. And the other thing is the stromal TILs, the cutoff is still being validated. Still not yet been completely validated. So a few of the centers have used a stromal TIL cutoff of more than 50%. Others have used more than 30% as well, as far as the stromal TILs are concerned. We have data from TMH also to that tune, phase 2 data again. But nevertheless, it's still a work in progress. But in this patient, with the MSI being low, TMB stable, PDL1 0%, I think I would stay away from IO.
Yes, sir.
So just a small thought. There are so many RNA-based signatures now coming out in absence of your immunotherapeutic marker. Do they are used, or in clinical, is it really valid? I want to understand from everyone's practice. Like the molecular signatures, especially gene expression signatures now, there are certain signatures which are respect to immunotherapy particularly.
Correct, ma'am. Like you rightly pointed out, I think it's not just about TILs alone. TILs, STAMs, T regulatory cells, T effector signature cells, they're all being looked at. In fact, the TF signature cells have been looked at in the IMPAR 150 trial as well, in lung cancer ABCP trial. And they looked at correlating that with the PDL1 expression as well. Unfortunately, all of them are still a work in progress. None of them have been validated as foolproof or robust biomarkers yet. So there are other factors in the tumor microenvironment which combine. And again, for example, the Tempus has got something like IPS, immunoprofile score as well, immune profile score, which puts together all of these, tries to put together all of these things. Again, the cutoffs for TMB on blood and on tissue are different. So again, the standardization between labs also is definitely not concordant there as well. So I think we don't have that single perfect biomarker for actually looking at who's going to respond to IO. But looking at the tumor microenvironment will probably give us a clue, like for this patient with an MSI low, TMB being stable, and also the PDL1 being 0%, you could probably say, this patient is likely to have an immune cold microenvironment. And again, looking at the molecular subtypes, there is a subtype called basal-like immune activated and basal-like immune suppressed as well. So if you want to do a gene expression profiling and look at identifying the exact molecular subtype of TNBC, then looking at early in your treatment, we are still light years ahead of actually trying to get that into clinical practice. As of right now, it still remains in research.
Thank you, sir.
Thanks, Dr. Kripa. As Dr. Kripa said, we really want to know how robust the biomarker is. The problem is, one is the cost of the testing itself. Even here, I think Dr. Mangai has done a comprehensive genomic panel. She got a HRD positive, but still we are discussing whether we can send that sample for different lab to make sure the HRD is really positive. So one is how robust the marker is and how good or how validated and how confident we are our own labs when the report comes, and the cost of the final treatment. All these things are quite complicated. Really, over a period of time, we need to analyze all these cases to see what's happening, how much really it mattered for the clinician and for the patient. That will really throw us a lot of light on all these things. Thank you. Dr. Mangai, I think it's quite complicated case. I think a lot of people have put their inputs.
Yes, sir.
Will be really interesting. Like we would like to know what really happened to this particular patient over a period of time,
Yes.
and what next you are going to do. That is also I want, because most of us are in this scenario. We have all reports, but finally we couldn't offer much to this particular patient because of financial problem, and the report is not targetable. Many like whatever we have seen, it's not targetable. So let's see what happens. We'll get the details of this particular patient to see how much the molecular tumor board really helped you. Thank
Yes.
you. Over to Dr. Narendran. You can give us
Thank
a consensus, and we can go with the next. Thanks, Mangai.
Thank you.
Just wanted to know here, any option of enrolling the patient in a trial which involves any inhibitors of MCL1? Any trial can be which the patient may benefit. MCL1 inhibitors, any idea is there, sir?
Not sure if there are any phase 2 or phase 3 trials which are ongoing right now in India, Narendran. But probably global trials. We'll have to look at probably global trials and probably early phase trials as well. But
some reports of just searching in the Google, some reports are there with MCL1 inhibitors, but all are not clinical and other.
Much rather, we could look at trials for enrolling this patient into Seshachalam govitecan, if those are open anywhere. That would be a better option because that's already an approved option, and this patient, if the patient can't afford it, would be a better option, Narendran, to look at enrolling the patient into a trial for Seshachalam govitecan (SG), and also recheck the HER2 receptor status like we've discussed earlier.
Okay.
I agree with Kripa. Actually, Seshachalam or Dapotumab, both will be the ideal if the cost is not a problem, or we have some trials where we can send these patients. So it will be of a young patient, PS1, she's telling, TNBC, resistant to all options exhausted. Ideal is to put her in clinical trials. That is the ideal situation. Okay, Narendra, can we summarize so that we can go to the next?
Last patient summarize to consider for head-to testing in the repeat biopsy specimen, and probably enroll in some clinical trials if possible for Seshachalam govitecan and other, if not affordable, maybe next line of chemotherapy.
Check the AR status as well.
So AR status, what if it's strong positive, or what is the clinical implication here, sir?
Bicalutamide can be given, sir. For some patients, they respond.
Correct. Abiraterone and enzalutamide also have been tried. There is, like phase 2 data on the same as well. So once you've exhausted all standard of care options, or if the patient can't afford what's next, and if the patient can't get enrolled into a clinical trial also, you could definitely go ahead and offer androgen receptor directed therapies like enzalutamide, depending on whatever the patient can afford.
Okay, sir.
Thanks, Kripa. We'll go to the case 4. Case 4 will be by Dr. Gopalakrishnan, Meenakshi Mission Hospital and Research Center. Over to you, Dr. Gopalakrishnan.
Good afternoon, sir. So can you hear me, sir?
Yes, we are hearing.
Good afternoon, one and all present here. I'm going to present the case of 42-year-old female patient initially evaluated for abdominal distension and leukocytosis. On examination, she had a splenomegaly of size 10 centimeter below the left postal margin. Next slide, please. Initially, she was evaluated by bone marrow biopsy and aspiration. Bone marrow biopsy showed hypercellular marrow and myeloid hyperplasia. And patient bone marrow was sent for bone marrow karyotyping and MPN reflex panel and BCR-ABL, qualitative BCR-ABL. And karyotyping came out as there is no metaphasis in the sample. And MPN reflex panel showed both BCR-ABL gene detected and the JAK2 V617F mutation detected. And qualitative BCR-ABL showed there is no BCR-ABL transcript detected. Any major, minor, and micro transcript were not detected. So because as both BCR-ABL and JAK2 mutation were positive, patient was initially started on Imatinib 4 mg OD, and BCR-ABL fish was sent and the NGS MPN reflex panel was sent from the peripheral blood. And after 3 weeks, the report came, fish BCR-ABL came out to be negative. And the NGS MPN panel showed a JAK2 exon mutation. And after which the imatinib was stopped and started on hydroxyurea 5 mg OD, and patient was on hydroxyurea since August 2024 till now, and patient status was till last 4th of this November. Patient has stable disease of hemoglobin of 11 and TC of 14,000, platelet of 2 lakh, with the spleen has decreased from 10 centimeter to 4 centimeter below the left costal margin. So my question to the team is, in this patient, actually the RT-PCR has showed both BCR-ABL gene detection and JAK2 mutation is there. But in other test, in the BCR-ABL fish and in the qualitative BCR-ABL showed negative for BCR-ABL. So is there any other test we have to do to confirm this as a this is CML, or we have to take it as a MPN only, sir?
Thank you, doctor. I think over to molecular experts.
Yes, sir.
Yes, sir.
So the fish is negative and RT-PCR is positive.
Yes,
generally, fish is good sensitive, and irrespective of the type of transcript that you have for BCR-ABL, fish should pick it up. The JAK2 is definitely positive because I see a excellent depth of sequencing. 76,779X is a very good depth of sequencing, and the VAF is also pretty high, 91%. So I would suggest you to repeat the BCR-ABL maybe by RNA sequencing.
Okay.
You do have leukemia panels which detect RNA fusions. So if at all it's one of those rare fusions, it will, I think RNA sequencing can give, because I don't know what else to do, because two different methods giving contrasting results. I think you should orthogonally test with a third method, and RNA sequencing is a very good and well-validated technology, one. Secondly, there are possibilities of generally higher false negatives to be possible with RT-PCR. False positive, I'm not really sure. So that's why even I'm not sure which is really wrong. And fish, they have counted enough number of cells too. 200 is a very good number of cells they have counted. So I think it's prudent to recheck it with RNA sequencing. Even the rarest of the rare fusions will be picked up by RNA sequencing.
Okay, sir. Thank you, sir.
Anybody else? Dr. Kiran, Dr. Vijay, any thoughts? Anybody else want to share any suggestions in this case? It's an interesting case.
So what is the possibility of overlap of CML with myeloproliferative here? So the PCR, if it picks up, it is sensitive, so we should at least see the we'd have see the qualitative PCR. The
qualitative PCR done, sir. Qualitative BCR-ABL done. It is not detected, sir. Showed no transcript were detected, sir.
Okay, then which one you said initially PCR was detected, no? BCR-ABL.
That is MPN panel, MPN reflex panel, sir, by RT-PCR, real-time PCR. That showed actually BCR-ABL gene detected, sir.
That is qualitative, no? They do qualitative PCR only.
Yes, that is qualitative, sir. Actually, that is actually sent by SRL, sir.
Can you go to the report, please?
Dr. Narendran, qualitative PCR and RT-PCR are the same technology. In qualitative, you add the reference, standard reference to quantify the amount of PCR-ABLs that are there in the quantitative PCR. But I think technology-wise, it's still RT-PCR, and they have done that, and that came out positive. It's in the next slide or in the next page.
My thought is that this patient has a pre-existing myeloproliferative disorder with some clones of CML coming into. That's why it's picked up only in the bone marrow, not picked up in the peripheral blood. That's what I thought.
So, interesting. I mean, like, have you done on the bone marrow aspiration? Have you done a karyotyping, conventional cytogenetics?
Yes, sir. Done, sir.
What is the report on the conventional?
Actually, they showed there is no.
No 922.
Yes, sir. The karyotyping, actually, they showed there is no this thing. There is no any metaphases, sir. So they didn't say any results, sir.
Okay. Not performed. Okay, they were not able to do it because of metaphases. Okay, so I think that's worthwhhile if you could do it. Do a karyotyping as well, or cytogenetics as well. That will probably help. In throwing some more light. But if you've already done another PCR you've done another PCR that's negative and the fish is also negative.
No, was that done after starting hydroxyurea?
No, sir. No, sir. Initially, all the tests were done initially, sir. After, initially first we
started imatinib for 3 weeks, right?
Yes, sir. 3 weeks after that only. Before starting imatinib itself, we sent all the reports, sir.
So you sent a reflect testing.
Yes, sir.
And it came positive. BCR-ABL was positive and JAK2 was positive.
Yes, sir.
Then you would have started on imatinib, right?
Imatinib, yes, sir.
And you sent again for RT-PCR for BCR-ABL, right?
No, sir. We sent again fish BCR-ABL, sir.
Okay.
And NGS we sent for from peripheral blood. NGS we sent for MPN reflex panel, sir.
Okay. Okay.
Oh, no. I'm sorry. I'm getting confused. Yeah, I'm getting confused.
From bone marrow or peripheral blood?
Peripheral blood, sir.
Can you? Okay.
Arun, they sent initial bone marrow reflex testing has been sent, RT-PCR. Then it came 2 positive. Then they again sent for NGS and fish, I think, in the peripheral blood, and then started on imatinib.
A fish is bone marrow. It's written here.
Right.
Actually, fish sample type peripheral blood.
No, here it's written bone marrow within brackets.
So actually, we sent peripheral blood, right? That actually after initial bone marrow we done and sent for PCR. The PCR report came after 2 weeks, 3 weeks. Then after that we have sent only peripheral blood, sir.
Okay.
Fish on a peripheral blood missed things. I think bone marrow would have been the ideal way to go about it.
Yes.
Right. I think probably they're doing interface fish alone, but then again, like all of us are saying, I think doing on metaphases will probably be better, especially on the bone marrow. And they're saying the conventional cytogenetics also was not being able to done. I mean, it was not done, or they were not able to do it.
They're not able to yield enough metaphases. So I think
doing a marrow now, after stopping hydroxyurea for some time, doing a marrow, redoing a NGS and cytogenetics will be a right thing to do now?
Yeah, I think so, sir. That is broader leukemic panel with from the marrow along with cytogenetics.
There is total difference between CML and the way we see the prognosis, everything is different.
I think some overlap is there, which is some kind of CML overlap, which is starting now with the pre-existing myeloproliferative.
Correct, but then the JAK2 positivity as well, right? Because it's a V617 on Exon 14.
Definitely, that is there, sir. Whether CML clone is coming up, that is a possibility. It was only picked up in the marrow.
I thought probably early myelofibrosis as well, pre-fibrotic stage of myelofibrosis as well here, based on the marrow findings. Because on the marrow, it says hypercellular marrow and myeloid hyperplasia. And what about the peripheral smear as well findings? Did you have a myelocyte bulge? Initially, I'm talking about at diagnosis, you would have sent for a peripheral smear, right? Did you have a myelocyte bulge, which is classical of CNV?
So actually, that report actually is not attached in the file. Right?
You can look at checking on that.
Because bone marrow biopsy also. What is the bone marrow aspiration morphology report? What is the bone marrow aspiration biopsy?
So it is there, sir, in the report.
It is there, sir. Hypercellular marrow, some myeloid hyperplasia, and increased MIGS, and there is no increase in blast. And there is no blast or no increase in blast. So hypercellular marrow, myeloid hyperplasia, and increased megakaryocytes. No increase in blast. So, I would probably, with this molecular finding, with this report and based on the bone marrow findings as well, I would probably tend towards JAK2 positive MPN, probably pre-fibrotic phase of myelofibrosis, given that the patient is presented with huge splenomegaly as well as responded well to your hydroxyurea. The counts are settling down, and here the hemoglobin is also high, right, at presentation.
So at presentation, even in between.
It doesn't fit into the criteria for polycythemia. Did it at diagnosis upfront?
No, sir. At front, it was not fitting, sir.
Okay, it didn't fit into polycythemia. Okay.
Fine. I think if all of us agree, then probably we can redo the testing after stopping hydroxyurea for some time. Redo the testing.
We talked about redoing a bone marrow, sir, or
yeah, bone marrow, cytogenetics, and NGS.
Right.
So what is the hematological response and you said stable disease, or what is the hematological response? Hemoglobin, everything is counted now.
So count has come down to around 14,000, sir. Hemoglobin was 11. And the spleen is also has decreased, sir, from 10 centimeter below the left costa margin to 4 centimeters.
Can a FISH be done on the initial bone marrow slides per se? BCRA will just use. I think that is one option, right?
If it is if tryptophan is there, it can be tried.
I think instead of doing another bone marrow might be easier, practically speaking. And since that would be the original one and it would not have been influenced by any of the treatment that we have given, a BCR-ABL FISH on the original bone marrow would be an option.
Yeah, that's definitely valid. If possible, you can look at doing that, but I think, just check on your initial peripheral smear report as well. And, like rightly pointed out, go ahead and look for a myelocyte bulge and also, see if you can do a FISH on the upfront marrow as well.
Okay, sir.
Can I just tell my suggestion? I thought if we do FISH from the bone marrow biopsy sample and then we wait and watch. If on progression, we may consider since the patient has responded to progression, if count is increasing, then may consider marrow and do NGS. Because now we have to stop hydroxyurea, everything, and then we have to go and do the marrow again.
So if we can do FISH on the original biopsy, I think we can wait for that report, right? We can continue hydroxyurea. We can wait if the FISH biopsy is there, it's possible. Then continue the same treatment, continue hydroxyurea, wait for the FISH on the original biopsy report.
Yeah.
We just need to see if the labs would be able to do BCR-ABL FISH on the block, because most labs would have standardized only for a liquid-based FISH for BCR-ABL rather than a block. So just ensure the lab is equipped or has the expertise to do that. That's another technical glitch you may come up with.
Okay, sir.
Because biopsy, tissue-based FISH is a different ball game or a different set of protocol compared to liquid-based FISH.
So what if FISH is not? We cannot do FISH. What is our suggestion from the panel?
Yeah, I think we'll go ahead and continue hydroxyurea. See, I think from the presentation also, it is not looking like classical CML because there are no high counts. Not in terms of lakhs anyway, for sure. Hemoglobin was also high upfront at presentation. Bone marrow doesn't show any blasts, or at least from the report that's been shared as well. We don't know the upfront peripheral smear as well. And again, if you look at the NGS, apart from the JAK2, all the other BCR-ABL-like mutations have also not been detected. So, I think it's fair enough if you to call it, put it down as an MPN, JAK2 positive MPN, probably early myelofibrosis or pre-fibrotic stage of myelofibrosis, and continue with the hydroxyurea and probably, even use ruxolitinib, JAK2 inhibitors at progression. And at progression, you could look for doing a repeat marrow and looking for additional cytogenetic abnormalities, ACS as well. If you can't do a FISH right now, based on the upfront marrow from the marrow.
Thanks, Kripa. I think My thought is doing a marrow now, because initially whatever the negative report was from the peripheral blood and positive report came from the marrow, and now the patient is on hydroxyurea, not on imatinib. Doing a marrow now, and if at all upfront biopsy is not possible, cannot doing fish, doing a marrow now, doing a cytogenetics and NGS can be discussed with the patient. I think because the report has come positive, these things has to be disclosed to the patients. And if the patient is willing, send now or wait till progression. Both can be done. But this should be shared with the patient.
So the problem is, if it is some clones of CML is there, if patient already on hydroxyurea, whether that clone is active enough to be picked up now, also we don't know, sir. Again, it will give a
if it picks up, it's fine. You made an attempt. You need to explain to the patient. If it picks up, you know that by hydroxyurea, molecular CR is unlikely. Okay, definitely marrow. If at all there is a CML, it should pick up. Okay, so if at all imatinib, we do understand. Imatinib is stopped only on hydroxyurea. That option can be discussed either now or on progression. That option can always be discussed.
It's interesting because probably was it low level false positive upfront or a technical artifact? I don't know. I'm not sure. Probably Arun sir, you can help throw some light on that.
So sorry, low level positivity in the beginning, sir.
Yeah, at the beginning, sir, and based on the RT-PCR report, or could it be like a chip?
Possible. Could be a low level positivity. But what is surprising is not a single cell in the bone marrow actually had this 922, which is where I'm a bit perplexed. With a good count of 200 cells. Yeah, very possible. That's why transcript, RNA sequencing can really throw light. Its sensitivity is also pretty good, very good, and rarer transcripts can also be picked up. Typically, when you have this MPN and CML overlaps or non-classical CML presentations, you tend to have the rarer transcripts.
Yes.
Great.
Thank you.
So
I think we'll consolidate. Yes.
So this patient with JAK2 positive MPN with possibly overlap CML. So since there's confusion is there, is possible this one BCI fish from the bone marrow biopsy specimen, if possible, if the lab is doing, or there are two options: either do bone marrow aspiration and send the NGS and cytogenetics now, or at the progression you can consider after discussing with the patient. Presently, continue hydroxyurea if you're not considering bone marrow aspiration.
RNA based NGS. Yeah.
Thank you.
NGS with RNA base also.
Thank you, Narendran. We'll go to the case 6. Case 6 is by Dr. Sneha Ujjaini, Sri Shankara Cancer Hospital Research Center. Over to Dr. Sneha.
Hello. Good afternoon, sir. My case for discussion is a 41-year-old female. She has no comorbidities and with a family history of CA endometrium in mother and her maternal grandmother. So the patient was diagnosed in 2009 and she has actually undergone bilateral lumpectomy, the details of which at the time of presentation was not available to us in 2009 and 2011 according to the patient's history. So she in 2021 she presented with a lump in the left breast. It was evaluated at another center, not in our center, and subsequently the patient underwent MRM and her hormonal status was ERPR negative and HER2 was 3+, Ki67 was 25 to 30%, and androgen receptor was very strong positive, that's 90%. So patient received her adjuvant 8 cycles of AC and docetaxel with trastuzumab and adjuvant RT, and she also received a maintenance trastuzumab for 16 doses. But in between, during the time of completion of the 16 doses, she had a delay of 3 months or so. So in that time, she again had a metastatic disease, like she progressed on maintenance trastuzumab, she had skeletal mets. So she was changed over to TDM1, and patient has received TDM1 from July 2023 to August 2023. And then she subsequently had local progression, nodal disease, and also skin recurrence and skeletal metastasis. So the course was changed over to lapatinib, capecitabine, and there was a partial response in the other sites, and there were few new lesions in the right axillary region. Again, her treatment was changed to docetaxel, and she also received FESGO. Then, after 6 cycles of docetaxel and 11 doses of FESGO, her interim PET showed good response, so we put her on maintenance FESGO. Subsequently, in November 2024, when her PET was repeated, we saw that she had a disease progression. Now she was presenting with brain mets as well. And at that time, when we did an right axillary node biopsy, it was ER0, PR3, and HER2 was 3%, Ki67 was 30%. She was now initiated on gemcitabine and carboplatin, pertuzumab, trastuzumab. And again, she had a progressive disease in February, within 2 to 3 months. So we changed over to TDXT. Then the subsequent PET showed good response when the patient was started on TDXT. So we continued it for up to 8 cycles. Then we repeated a PET in the month of October 2025, and then it showed a disease progression. The rebiopsy, her ER status was Aldrich score 2, PR was 4, and HER2 was 3 plus. So now the patient is currently on tucatinib, capecitabine, and trastuzumab. She has completed 2 cycles so far. So we got her NGS also done, and the NGS says MSH6 positive. It is a variant of uncertain significance. So the question to the board was, after multiple lines of chemotherapy, the patient has already progressed on the options. She's pretty much exhausted all the options. So we wanted to know if at this point, if there is any role for the immunotherapy we can add on based on the Panacea trial, if we can try this for this patient, because she's doing good GC wise except for the disease progression in the imaging. And also, given the NGS report of MSH6 being positive, any role for family members testing?
Thank you. Thank you, doctor.
Thank you, sir.
Over to the panel. Who would like to start? I think we'll go for the MSH6 next. Probably the first, Dr. Kripa, your thoughts?
Yeah, hi, Zara. So I think for me, immunotherapy definitely not an option because based on the VUS, absolutely no role for combining it with HER2-directed agents. And I just wanted to ask the presenter, what is the response to the current line of the HER2-directed therapy? You said patient is on tucatinib plus trastuzumab.
She has just finished only 2 cycles. So we started on October 27th. So as of now, she's just received only 2 cycles.
Cycles. And if she's responding to the current line of therapy, yes, you could go ahead and continue with the same. See, the only agents that she's probably not been exposed to until now are margetuximab, which is already FDA approved, but probably you'll have to check on a CD16A genotype analysis and see if she's a CD16A carrier. It's then going to be option number one. The other option, I'm talking about all of this at progression.
Yes,
the other
sir.
Pyrotinib as well, which is again, not yet FDA approved, but already phase 3 trials are positive. And then, if not, you'll have to look at bispecific antibodies, enrolling the patient into a clinical trial for HER2-directed bispecific antibodies, like zanidatamab is a class and example. And already phase 3 trials are ongoing for zanidatamab as well. If not, for zenocutuzumab, and the other option is ricitamab vedotin. So all of these are ADCs targeting HER2, which could be the bispecific antibodies. So that's all for later lines of therapy. If you've exhausted, if the patient progresses on your current tucatinib plus trastuzumab plus capecitabine as well.
Okay.
And adding IO, remember the MSH6 that you picked up is a VUS.
Yes,
so you
sir.
can add VUS. So it's got no therapeutic relevance whatsoever. So adding IO absolutely not a given at this point in time. There's no role for adding an IO to your HER2-directed therapy. And the last biopsy, when was the last biopsy done? And was it 3+ on IHC?
IHC, yes, sir. HER2 was 3+. It was done in October before we started her on tucatinib.
So I think then that's as far as the therapeutic recommendations are concerned.
Okay. Okay, sir.
Thank you, Dr. Kripa. I think we agree there is no role of IO. And it's a VUS, definitely we cannot attach much significance. We need to send the patient for genetic counseling. And we need to decide whether we are going to test the family members or just follow up. Probably genetic counseling, post-genetic counseling, that can be decided. So not much attach much significance to the VUS as such. And based on that, definitely immunotherapy may not be the right option. So anybody else, Dr. Kiran, Dr. Vijay, any thoughts on this case? Or we can just go for the consensus?
No specific thoughts.
Okay. Okay.
Oh, can I just add a point here?
Yes, sir. Yes, sir.
Yeah. So I just wanted to know right now, as Dr. Kripa said, if the patient is responding very good, maybe in the next line of therapy choice, you might want to do a somatic testing, because what has been done only is germline testing.
Yes, sir.
So comprehensive genomic profiling, looking at any rarer targets that may come up possibly is something that you might also want to consider.
Okay, sir.
Completely agree. I think, you should look at doing, somatic mutational analysis, looking for tumor agnostic markers as well. So that will help add progression.
Sure, sir.
Thank you. Narendran, can you?
This patient had to positive metastatic CA breast post multiple lines of therapy. As of now, on tucatinib and trastuzumab. This patient is responding to continue the same line of therapy. Not to add immunotherapy based on the VUS, and on progression may consider somatic repeat biopsy and somatic mutation NGS along with MSI and TMB if possible. And if there's no targeted mutations, in addition, may consider other ADCs which target HER2 or pyrotinib, whichever is feasible.
Okay, sir.
Thank you. We'll go to the,
thank you, sir. Yeah.
Thank you, Dr. Sneha. We'll go to the case 7. It's my case. Proceed. Next slide, please. So she's a 72-year-old, primary peritoneal carcinomatosis. Stage 3C, actually initially there was a pleural effusion, but tapping was negative. So stage 3C, treated outside, good PS. Family history, her brother had a history of malignancy. Next slide, please. So after the patient received first line paclitaxel was given, had toxicity, anaphylaxis to paclitaxel, so changed to gemcitabine cisplatin. Had very poor tolerance to gemcis actually. So severe thrombocytopenia, grade 4 thrombocytopenia was there. So next slide, please. So they after 3 cycles of gemcitabine cisplatin, they continue only weekly cisplatin, and repeat imaging was done. Next slide, please. So repeat imaging was done. Repeat imaging showed good response. Pleural effusion has disappeared. Patient underwent interval cytoreduction. So post interval cytoreduction, patient was almost 2 months it took for her to come out of the post-operative period. So she was treated outside in Ahmedabad. So she traveled back to Trichy, and she came to me after 2 months of the cytoreductive surgery. So by that time, they sent the NGS report also. They sent the tumor sample for the NGS report. Yeah, just scroll down. So TMB was low, MSI was low, ATM gene was positive. Next slide. So HRD was positive. It was very high. GSS score was 80. So next slide. Okay, go back to the opening. So within 2 months, she came back to me. So that time, because her tolerance was poor for the previous cisplatin, even with weekly cisplatin, she had the grade 4 thrombocytopenia. And she completed almost 3 months of gem cisplatin. After discussing, we put her on PARP inhibitors. So almost 15 days PARP inhibitors she took, and then she came back to us. Then that time on examination, she had peritoneal deposits. So CT abdomen was done, that was proven. Biopsy was done, recurrence was proven. So we have a HRD positive case. HRR DNA repair gene ATM was positive. 72-year-old, poor tolerance. She is not even tolerating gem cisplatin. And PARP inhibitors was started 2 weeks. We don't know whether she's resistant or it took some time. 2 weeks is too less for us to document any response with PARP inhibitor. She had a progression in the abdomen. This is the scenario. So my question to the panel is, at this point, whether you will continue PARP inhibitors. Definitely she is not tolerating gem cisplatin together, or at least weekly cisplatin for some time. If she responds, then change to PARP inhibitors. We can't call it as a platinum resistance because she received platinum, she took surgery, and it took almost 2 months. Platinum was not completed. Before that, she has recurred.
Carboplatin sensitivity, sir. I mean, she is reacting.
She was started on carboplatin initially, but because of myelosuppression, they shifted to cisplatin. And she was on cisplatin before coming to me, almost some 2 months of cisplatin, weekly cisplatin, some 8 doses, total cumulative doses of 240 milligram per meter square of cisplatin she has received.
And because of the myelosuppression, because we gave full 3 weekly doses of carbo, can we do weekly carboplatin? With the single.
The problem is every time she lands up with thrombocytopenia, even with cisplatin. I thought with weekly carboplatin, even more myelosuppression will be severe. If at all there is a chance, weekly cisplatin, starting weekly cisplatin will be better rather than going for carboplatin. That's what my thought was.
Okay, sir.
Agreed. I think like we always keep talking about the platelet sparing effect of Taxol. Carboplatin alone as single agent causes more thrombocytopenia than when you combine it with paclitaxel. And again, that's something just for the postgraduates here that I always keep talking about. So we talk about, and the mechanism behind is what I'm trying to tell you. There is always P glycoprotein mediated efflux of paclitaxel and GST or glutathione S transferase mediated detoxification of carboplatin. And the synergism between these two is what results in a relative sparing of the colony-forming unit megakaryocyte, CFUM. And that is why you have lesser thrombocytopenia because of the platelet-sparing effect of Taxol. Whereas you give carboplatin alone as single agent, you're likely to end up with more thrombocytopenia. So Arun sir, again, coming back to your patient, this patient, what was the response to platinum, sir, upfront? I mean, like
She
when
responded, like she was stage 4A, she had present with pleural effusion. She responded to the extent that they were able to do a optimal cytoreduction. CT done immediately after surgery was normal actually.
Oh, meaning she CR, sir? Is it a?
She's not CR. Pathologically, she was probably, yeah, it was, she was not a pathological CR. She responded and went on to complete cytoreduction.
Okay, sir. And now this last 3 cycles that you've given weekly platinum, how's the response to that, sir? Weekly platinum as well?
Actually, last see, the patient received platinum before surgery. Surgery was done. 2 months gap for all the shifting. She came to me. Then PARP inhibitors, after discussing all the toxicity, we just started on PARP inhibitors. 72 hours, she was not tolerating. So PARP inhibitors was given. Within 2 weeks, she landed up. Clinical examination, there was a peritoneal deposit. Biopsy was proven. Then, because previously she received gem cisplatin, that's where responses. We gave 1 cycle of gem cisplatin. Day 8 of gem cisplatin, she came with a platelet of 12,000 and WBC of 2,400.
Okay.
Presently, she is admitted with myelosuppression for just 1 cycle of PS is good, but she has extreme sensitivity or toxicity to cisplatin. So I was just thinking, only cisplatin, weekly cisplatin, check how is the response. Then if response is good, probably a 2 months shift to PARP inhibitors. If response is not good, it's not behaving like HRD positive, probably think of something else.
So I agree, sir. I think, from the last platinum, until now, if it's been less than 3 months, then you could probably call it as platinum refractory disease as well, even though if it's been post-surgery as well. And then now as well, I mean, you've restarted platinum with just a single cycle, and then she's already come back with a platelet count of 12,000. I don't think how feasible it will be for you to continue with platinum anymore, sir. And again, interestingly, as far as this ATM mutation is concerned, even if people develop resistance to PARP inhibitors, a lot of trials looking at combining it with ATR inhibitors. You're trying to resensitize them towards platinum. So like for example, serlasertib, berzosertib, these are all in phase 3 clinical trials as well. Combinations looking at resensitizing them towards platinum. So that's another option. You could look at probably enrolling this patient onto a trial if that's feasible. So that's just another point that I thought I should highlight, sir.
Okay. So
Because
this patient 2 weeks is too early for us to tell it's a progression on PARP inhibitors, right?
2 weeks is probably too short time, sir. But the problem is, if the patient is progressing right now, then that probably tells you that the biology of the disease is pretty aggressive. Because it's been, like, say, for example, 3 months or 4 months from the last platinum, sir. Is it around?
Yeah,
Roughly?
3 months. 3 months.
So, that tells you that even if it's a relapse, it's come back pretty quickly. I mean, like, biology is pretty bad. So she definitely is not going to be, the prognosis is not going to be great. Given the fact that even though she's HRD positive and the ATM, she's got an ATM mutation as well. So if you can, I would probably suggest combining PARP with ATR. Again, same, the concept of synthetic lethality here as well for the ATM and the ATR inhibitors.
Okay. Thanks. Any other suggestions from others?
Yeah, just a question here, doctor. Already the patient having severe thrombocytopenia, addition of PARP inhibitor wanted further aggravate myelosuppression.
See, the patient presently we started on gemcisplatin doublet with a compromised dose was started because she responded to that regimen previously. So with that, she landed up with after day 1, she landed up with thrombocytopenia, and so now we know that doublet is not possible for this patient. Either we need to go for only platinum or continue PARP inhibitors alone, but that is not possible because in 2 weeks she progressed. So we don't know whether. So either you continue only platinum plus PARP inhibitors, or only PARP inhibitors, or the other option what Dr. Kripa said is ATM plus ATR gene inhibition. Both probably as that combination can be thought of.
Definitely. Yeah. Thank you.
Thank you. Okay. Kripa, Narendran, can you just make the consensus? We'll go to the next.
So you mean ATR inhibitor in this patient, sir? Enrolling in trial.
Correct.
So with so much cytopenias, I don't know whether trial we can enroll her.
So Narendra, that's going to be the even if you want to contemplate platinum as well, I don't think you can give platinum also with such a low platelet count. So even, for example, even if the different PARP inhibitors, the toxicity profile is different. We now have access to niraparib as well. But nira and rucaparib, the incidence of thrombocytopenia is much higher. Olaparib, it's more of anemia. Just to compare, between the 3 PARP inhibitors that are available to us, we don't have access to talazoparib or any of the other PARP inhibitors. So I think, having said all of that, we're talking about only if the patient's platelet count starts improving, are we going to contemplate further therapy as well, be it even platinum or PARP inhibitors or a combination of PARP plus ATR inhibitors. But one way of resensitizing these patients towards platinum is by doing this combination, which I can exploit synthetic lethality, just like how you would do it for anybody with a HRD or a BRCA mutation, and then you add PARP inhibitors to it. The same concept applies to ATM mutation and ATR inhibitors. So, and that's where there are ongoing phase 3 trials as well as we speak. So.
Okay. This patient, the final consensus.
If you think it's definitely platinum resistant, it's not responding again, then you'll have to go down the same route as earlier. How we treat platinum resistant again, FLORA receptor testing, mirvetuximab, that's an option. Otherwise, again, based on the relacorilant plus nab-paclitaxel or nab-pacli plus bev, and you can add pembro as well. Now that we have the data, we've discussed that during the last tumor board as well. If it is
probably weekly cisplatin here, and if it's not responding, then you go for platinum-resistant ovarian cancer treatment. If responding, then probably a PARP inhibitor with ATR inhibitor.
Correct.
Is that right?
Correct. If it's responding, if it's platinum and platinum responding, go ahead and do that. If not, we go on to the platinum-resistant algorithm, look for the FLORA1 testing, and if not, then nab-pacli plus bev with pembro as well. Or the relacorilant plus nab-paclitaxel is the option if it's platinum resistant. If it's platinum sensitive, I think we stick to what we just discussed now.
Okay. If platelet improves and the platelet is fine with weekly cisplatin, any suggestion of adding bevacizumab here?
Yes,
it's normal.
That's an option.
It's an option for sure. Definitely, yes. Look at adding bevacizumab in this patient. Be it even if it's sensitive or resistant, definitely it's an option.
Okay. Okay, sir.
Thanks, thanks, Narendran. We'll go to the case 8. So case 8 will be Dr. Shervin Venati from MS Ramaya Medical College. Over to you, Dr. Shervin. Dr. Shervin, you are there?
Yes, sir.
Yes, please proceed.
Good evening, everyone. This is a case of 44-year male. The primary is right lung carcinoma, lower lobe, adenocarcinoma, ECOG performance status 1 with hypertension. Next slide. He was diagnosed in 3rd August, and the last follow-up, he has received 6 cycles of PEM-carbo along with Osimertinib. After that, there is a partial response to the disease. So we have kept him on maintenance pemetrexed and Osimertinib. And for his bone mets, he has received palliative RT to the bone and zoledronic acid monthly for 1 year, followed by 3 months. Next. The biopsy was taken not from the lung, it was taken from the paraesophageal lymph node in the first diagnosis, and it came out to be adenocarcinoma, positive for CK, TTF1, and MUC5AC and NAPSIN-A, and negative for P40, CDX2, synaptophysin, PAX8, and NKX3.1. NGS couldn't be done at that time because of the financial constraints for the patient. Next slide, please. And now, patient is on maintenance pemetrexed and Osimertinib. He has received 1 cycle of pemetrexed and Osimertinib on September 29. He is having right pleural effusion and the disease has progressed. The cytology from the pleural fluid came out positive for the malignant cells. Disease is progressing in both the primary as well as the metastatic sites. Now we are planning to start him on Amivantanib along with some docetaxel chemotherapy, but patient is not financially affordable for getting an Amivantanib. So the question to the tumor board is there any other alternative to the Amivantanib or any other thing which we can do?
Thank you. Over to the panel. Thanks, doctor. Over to the panel.
A repeat biopsy was not possible.
Repeat biopsy we are planning, sir, because the entire right lung is collapsed. We are now the
effusion and the cell block of that
pigtail was inserted and it was hemorrhagic. So the number of malignant cells are very less. So we wanted to do a biopsy to send for NGS. Now pigtail was inserted and pleural fluid we are draining. Once it drains, we will take a repeat CT and then plan is to take a CT guided biopsy.
Okay. So I think if you're planning for a CT guided repeat biopsy, probably you need to wait for the biopsy report, start on chemotherapy, wait for the biopsy, repeat biopsy NGS report. Then probably we need to plan accordingly. That's what my thought. Dr. Vijay, you are
same, sir. We can start with docetaxel, get a repeat biopsy done, check for the report, then think from them.
Yes, I think that will be ideal.
And one more thing, sir. As he has progressed on Osimertinib, is it beneficial to continue Osimertinib now along with dosi, or can we stop it?
Very, very good question. Most of us ask this question. We'll ask Kripa, we'll have data. Tell Kripa. Kripa, your thoughts, Kripa.
So this patient had only Osimertinib upfront, right? You did not give it a combination with chemo or only Osimertinib?
With chemo they have given. But with
PEM-carbo with Osimertinib.
See, now there is data, it's called the COMPEL trial, where they have looked at if somebody progresses only on Osimertinib, then you could probably look at adding chemotherapy at progression. And that has shown a PFS benefit. But if you've already used Osi plus chemotherapy upfront, then there's no point in trying to just switch the chemotherapy partner and continue with the Osimertinib with the same dose. So, I think like we've already discussed, you'll have to wait for the NGS pattern, look at identifying whether it's an on-target or an off-target resistance, and look at acting on it accordingly. And, if not for Amivantamab, then you could do, VEGF inhibition with taxanes also is another option. And if you feel Ramucirumab is also expensive, you could use even Nintedanib. Nintedanib is also an approved option, albeit in the approval is based on the EU, not FDA approved. but it is EU approved, European Union. So I think those are the options. And again, it will all come down to whether you have MET amplification, MET mutation, or MET exon 14 skipping mutation, or anything. And then, you can base your treatment choice accordingly.
Okay, sir.
Thanks, Kripa. Thanks, Chervin.
Good evening, all. I'm Dr. Zaran from Kozhikode. I hope I'm clear.
Yes,
Uh,
you're
So I'm presenting the case of a 33-year-old female. She has no previous comorbidities. She was admitted with the pulmonology department with severe breathlessness. Chest X-ray showed diffuse bilateral haziness. And then an HRCT thorax was done, and they reported bilateral diffuse GGOs. She had multiple above and below diaphragmatic lymph nodes. The pulmonologist initially was under the impression this could be a lymphoma, and he did a EBUS guided biopsy from one of the subcarinal lymph node, and it came back as initially the pathologist told us it is a NSLC. But then after her very extensive IHC, she has reported as poorly differentiated neoplasm. We discussed the radiology once again with the radiologist, and radiologist felt like this could be a lymphangitis carcinomatosis. Again, we did not know if primary was the lung. Any TTF1 was positive. It was poorly differentiated, but with the clinical picture, we thought this could be a mutated NSLC. And then we started her on single agent carboplatin. And we also gave her paclitaxel because we didn't know if this was indeed an adenocarcinoma. With this regimen, she actually improved. When she was admitted with us, she had hypoxia. She was dependent on O2. With carboplatin and paclitaxel, she improved. And then we sent for her NGS. Initially, the PDL1 report came. The TPS was more than, I think it was 10%. And then her NGS came back. And in the NGS, in the last sentence, they have written, MET amplification has been identified with borderline threshold by NGS, hence not commentable. So is that significant? Can we target the MET for her when she's young, non-smoker, no comorbidities? Is this indeed a MET amplificated NSLC? If not, she also has an ALK, which is VUS. Will she benefit with an NGS, a complete NGS? If not, if both are negative, can we target her with an IO? What additional can we do? We are planning to give her second cycle of paclicarbo.
Okay. Thanks, doctor. I think very valid MET amplification. So I can go directly to molecular specialist. Dr. Arun, Pushpa Singh, anybody wants to?
Yes.
Yes.
So this is definitely you need to retest it with a different method, ideally FISH. Because your MET targeting agents were also based on the clinical trial was based on copy number by the FISH. So strongly suggest doing FISH. The ALK that is picked up is a point mutation, if I'm right. So that was in this case, right? There was an ALK point mutation. Yes. So that cannot be that's not targetable here. I would also before that I would also suggest, was that PDL1 for this case?
Yes, sir. Yes, sir. It is. If you scroll down below, the report has been
okay.
uploaded.
It is TPS is around 8%. Okay. So I think see, this panel which has been done for NGS covers all major mutations like EGFR and ALK, which are definitely a no-no for immunotherapy. Just try doing a MET by FISH, and I think if that turns out positive, you do have a therapeutic option, and immunochemo is also not a bad option here, based on the 10% positivity of PDL1. And yes, as a molecular guy, I would always want to do a larger panel. And I think that does have some role here, given the ambiguity of the MET in this case.
Okay, thanks, Dr. Arun. Kripa, your thoughts?
Yes, sir. I think I'm completely on the same page. Definitely get a broader based NGS with tissue of origin testing as well, given that it's actually a poorly differentiated carcinoma and they've not been able to club it together. They've said probably a lung primary. So, my first choice would be to go for a broader based NGS panel, including a TOO testing, tissue of origin testing. And as far as therapy, obviously, this ALK mutation is definitely not targetable. So, no role for any ALK inhibitors here. This is not the ML4 ALK fusion that's been picked up. It's an ALK point mutation, which is not actionable. And as far as the MET amplification is concerned, the geometry mono 1 trial looking at capmatinib used a cutoff of more than 10. So you'll have to have a copy number variation or copy number alteration more than 10. So I would suggest getting a FISH done, and if positive, then you could look at doing it. But remember that the approval is only for MET exon 14 skipping mutations. It's not for amplifications in the first line setting. So, and if it turns out to be all the driver mutations are negative, then you could look at adding IO to your backbone if in case the MET is also not amplified adequately. And how about the performance status of the patient? I thought you said it's PS3.
So right now she's R42. She's if I can call her PS1, sir. She's responded excellently to Pacli-Carbo.
Perfect. Then I suggest that you keep going along the same lines and also add bone modifying agents as well because she's got multiple lytic lesions as well. So, probably contemplate doing that as well. Bone modifying agents, denosumab or zoledronic acid.
Yeah. So can we jump ahead with the IO along with Pacli-Carbo because MS and the MET mutation can be immuno-inducive?
So again, like I said earlier, you probably have to look at getting a broader based NGS panel and looking at the other factors as well. See, because the reason being that if it is MET amplification, see, we always talk about hot tumors and cold tumors, right? So conventionally, RAS, BRAF, and MET, these are considered to be warm tumors. They're not very hot, nor they're very cold. I'm talking about KRAS without a coexisting STK11 or KEAP. And again, BRAF as well, and MET. MET is considered to be slightly more warm tumor. It's not high, at least more than 50%, if you in the presence of a coexisting MET. So, and given that your patient has actually responded well to your platinum-based doublet, Pacli and Carbo, keep going with that. Get a broader-based NGS panel and look at a TOO testing as well, and check for the MET amplification. And if everything else turns out to be negative, then you can go ahead and add IO. That'd be my working algorithm.
And here, sir, basically, when you take a fusions here, there will be a very limited fusion testing done. So ALK, maybe EML4 being a common partner that might have been used here, but there are other fusion partners for ALK also. So again, as I said, the broader panel testing with the fusion partners again, that will also have a more chances of few more options of therapies here.
So Kripa sir, just a question. If any MET amplification or ALK, whatever the mutation is there, usually if it's aggressive, so the response to Pacli-Carbo is so dramatic the patient is well now. So what about whether we are dealing with a NSLC or a thymic carcinoma, like where initially the Pacli-Carbo have a good response, then later they will progress again?
No, agreed, which is why, they've called it a very poorly differentiated, which means it's very high grade and aggressive as well, the biology. And that's why I suggested do a, DNA plus RNA based NGS along with the TOO, tissue of origin testing. That will also help throw more light onto the picture because that will tell us either based on methylation based signatures or based on transcriptomics as to where the likely primary is to be from. And if that will, add more weight to your diagnosis as well. Probably if you're thinking of, a non-small cell lung cancer as is being treated now. So I think, do a broader based NGS that will solve a lot of questions. You could do either a Guardant Infinity or a Tempus. Both of them have TOO testing available. I mean, if cost is not a constraint, obviously, yes, that's the rider.
Okay.
Thanks, Dr. Kripa. See, it's always good to have a broader panel, but to me, since you have got excellent response with Pacli-Carbo and we don't have much actionable mutation to plan based on this, probably continue Pacli-Carbo and plan for a broader based NGS at the next when the patient progresses, probably rebiopsy and have a comprehensive genomic panel at that time. It's not a bad choice at all, but always having a broader base, even now, it is possible. Many times it's difficult. Now you have sent and there is not much of actionable mutation. And you had a very good response. So I would like to continue Paclitaxel in your case and do a comprehensive panel at the time of progression. That's what my thoughts for this case.
So Arun sir, would you want to add IO, sir? I think that's what.
Yes, I think yes, because 5% I think we can add IO with along with the chemotherapy, definitely.
So I think that's the only thing. Probably if there's a driver that's being picked up on a broader based NGS, then probably we can refrain from the IO and just continue with this. Because like you rightly said, she's been responding very well to Pacli and Carbo. So I think that's where probably a broader based NGS will help us also to decide on, to make that decision about IO or not. If you can pick up some other driver, or if it's been picked up on the broader based NGS, then you probably would sway away from IO. So I think that's one other reason why I think probably doing a broader based NGS right upfront would be a better option. If somebody's going to be able to afford it later on, I think they might as well be able to afford it upfront also, and if they can afford IO as well, that's quite an expensive molecule as well. So I think both ways, but I ideally like to do it upfront because in that case you'll always know whether the mutation has been present upfront or they're acquiring it later on as well. So I think it makes for me it makes a lot of molecular sense to actually go ahead and offer it upfront, and if the patient is willing to, go ahead and get it done. Because like you said here again on this, when amplification is borderline, they themselves have said that it's borderline. So you can't act on it even though you've done the test, like we just spoke about in the previous cases as well. So yeah.
Thanks.
So,
Narendran, can you summarize?
So this patient, 35-year-old female, poorly differentiated carcinoma, probably lung, with a good response to Pacli Carbo. The limited targeted panel, doubtful MET amplification is there, and ALK mutation with PDL1 score of 5. Consensus is to continue Pacli Carbo. If patient can afford immunotherapy, then consider for a broader NGS panel and tissue of origin test, and then based on that, add immunotherapy. Or other option, if cannot afford immunotherapy, maybe consider in progression the broader NGS panel.
Thank you, Dr. Narendran. Dr. Vijay, Dr. Kiran, any final thoughts? Or we can close the molecular tumor board and we can meet 2 weeks later. Anything you want to say, Dr. Vijay and Dr. Kiran? Okay. So thank you all. I think have a great weekend. It was excellent sessions, a lot of learning. I thank Dr. Arun Kumar, Dr. Silambarasan, Dr. Pushpa Singh, Dr. Mrs. Brinda. I thank all of you for all the experts. I thank special thanks to Krupa Shankar as always, Dr. Narendran for doing the consensus part. And I thank all the technical staff who have been behind compiling and doing the technical bridging so that the molecular tumor board happens smoothly and precisely. Thank you all. Have a great weekend. Thank you very much.
Thank you.
Thank you all. Thank you.